artery disease. Dr. Ashish Thakur, he is MDDM, FRCP, FESC, is a consultant cardiologist in Mid Yorkshire NHS Spire, Eland, Leeds, UK, chairman and chief cardiologist of Rhythm Foundation, UK, emeritus professor cardiology, IGIMS, Patna, India, Foundation Training Program Director of HIA. He is an honorary senior lecturer of University of Leeds and ILM 5 certified executive coach and mentor. His special interest on complex coronary artery disease, sudden cardiac death, atrial fibrillation, elder cardiology. He is author of many peer-reviewed studies, articles, textbook chapters, and regular speaker in international and national meetings. Dash to you, Dr. Ashish Thakur, over to you.
Very much. Good morning from West and Dr.
Sir, your voice is breaking.
Hello.
No, sir, you need to move closer to your mic.
Yeah. Am I audible? Can you hear me well, I guess?
Yes, sir. Better, sir.
Yeah, thank you very much. Well, first of all, I must thank the organizers, Dr. Sabu and the whole team for organizing such a wonderful conference, which I had a opportunity to participate last year as well, and perhaps the year before, if I remember correctly. My core job is of a cardiologist, and I'm going to be sharing with you my work or my perspectives over two decades of 25 years or so of what I've learned so far in this ever-changing, fast-paced world, where currently we're having to come to terms with, accepting that, unless we treat people medically properly, we're not going to get there, actually. So let's move on, and we're already running a bit late. So I would like to start. It's a really difficult day for United Kingdom and the whole world. And I must start by paying my tributes to our Queen, who passed away yesterday, and a legendary figure who would continue to inspire us for the rest of our lives and generations. Why do we worry about diabetes and coronary artery disease? Well, the whole business is about atherothrombosis, atherosclerosis. This is a pretty self-explanatory graphic where you can see there's so many complex things going on at one point in time to a different point in time as you go along the line. And you only need to look at one end of the spectrum to the other to try and get to see what, personally, I do not believe in the term called pre-diabetes, because, you're either a diabetic or you're not. So I think that should be going off pretty soon, in years to come, because the long-term outcome perhaps would be the same in terms of if you really have to worry about people. And that is actually the biggest iceberg, which is sitting behind the ocean, with so many people carrying a risk but not knowing it. However, to put that in context, this is just a graphic showing you what sort of issues the body, the vessels have to go through with time in order to get to a point where something might go horribly wrong and somebody could have a non-fatal or a fatal cardiovascular event. it's a complex syndrome, like any chronic disease, cancer, for example, and these are pretty much well known to everyone. But why do we worry? Because we need to treat so many factors in a diabetic patient with coronary artery disease, because there's so much going on, ranging from not just glycemic control, to the lipid aspects, inflammatory aspects, the dysfunction of the endothelium and the microvasculature, the actual obstruction which may be there, along with spasm or microvascular symptoms. And of course, if you've exhausted all the options, then treating them differently. And that's true about, you'd have seen hundreds and hundreds of diabetic patients with coronary disease sometimes coming back to you with recurrent symptoms and not happy with their quality of life. But we know more about things and how to handle all that, and the science around this is continuing to evolve as I speak. So this is perhaps just a summary. Now the goalposts keep changing, and this is the one from 2021 from European Society of Cardiology in terms of diabetes and cardiovascular risk. And you can see that, there's nothing called low risk. If you're diabetic, you at least have a moderate to high or very high risk. And I wouldn't dwell any further on this, but it just a snapshot of how, by simply having that label, even if you're under 10 years, with or without any target organ disease and no additional cardiovascular risk factors, you still have a moderate risk to be handled, let alone the duration, and let alone with established atherosclerotic disease. The key challenges, because I work on both sides of the continent, I've got people in care, under my care in India as well as here. I run a big charity for cardiac patients. So I keep learning interesting perspectives, and I'll show you a case from this morning about 2 hours ago. Every Friday I do a clinic, of course, virtually, and every few months in person for my charity. And what I've learned, which would perhaps resonate with the audience which is listening to this, that we see much younger ages. To the spread is quite broad. There's pretty much discrepancy in levels and type of care. Yes, we are able to reduce the mortality burden, provided the person can get timely intervention or timely treatment. We can't really define, we don't really know what's going on in rural, semi-urban, or sometimes urban areas where the morbidity mortality burden can be quite high. We don't have a national coronary artery disease register in India. If you diagnose somebody to have CAD, they don't go on a national database. We over and underuse medication, especially dual antiplatelets, dose of statins. We don't optimize the use of the modern medications for coronary disease in diabetes or at risk of diabetes, or so on and so forth. We over and underuse coronary vascularization, and you can have your own view about it. Maybe we may not be spending enough time with people about shared decision making and multiple opinions. That's, you ask me. I mean, the patient I've consulted today has been through 4 different centers, and that adds to the delays in prognostic treatment, non-prognostic treatment, or non-guidance directed treatment, so on and so forth. So these are some of the, it's not a comprehensive list, but you can keep adding to it. This is a case. If you can see the screen on the left side, there is an electoral lead electrocardiogram. On the right side, there is a coronary angiogram. This is a 55-year-old male I consulted this morning who's been to 3 or 4 hospitals. About 2.5 months ago, he's a diabetic, wasn't or isn't properly managed. There aren't any other reversible factors. BMI seems to be reasonable. He had a classic anterior STEMI, delayed presentation after about 2 days from one nursing home to another, where he could not be thrombolized. Of course, he didn't have primary angioplasty. Eventually, he landed in a government center where he had 7 or 8 days of stay, during which he had an elective cath, which revealed a tight LAD stenosis, as you can see perhaps on the right side of the screen. He was advised a stent to LAD or a PCI to LAD with an LV ejection fraction of 30% without any obvious consideration to the infarct-related territory and perhaps loss of viable myocardium in that territory. And he was eventually discharged on a small dose of beta blocker, a small dose of a statin, dual therapy, a small dose of ACE inhibitor, and a nitrate. And you can keep on guessing what all you could add to him for his prognosis, as well as perhaps quality of life and symptoms going forwards. Eventually, you can think of and ask me the questions what I did to him, but I'm sure the answers are pretty much self-explanatory. The silent myocardial ischemia, I'd like to just briefly mention it because this has been dealt with in the past quite aggressively as to, about 2/3 of ischemic episodes in somebody would be asymptomatic. And it may or may not cause some symptoms. You might be able to find something on ECG. You might be able to find something if you do a thallium scan or a stress echocardiogram. It was thought to be impacting prognosis. There was a proper classification, and initial studies, hinted that revascularization could be better. But then it's all been overtaken by the ischemia trials, as you would perhaps refer to. For those with interest in cardiology would know that the ischemia study completely kind of decimated this fact that if you offer them revascularization, they do better. No. Well, about 30% of the population of 5,000 people in the randomized setting were asymptomatic, and 40% of the total patients in the ischemia trial were diabetics with no benefit whatsoever in terms of symptoms, symptoms-wise, there was some benefit in people with daily angina, but otherwise there was no prognostic benefits or hard endpoints in people who were offered initial invasive treatment. So in the elective setting, I think we need to see what symptoms they have, what is the grade of symptoms, what is the glycemic control, how are their other organs functioning as a holistic physician. And this is exactly what I said in the APICON. I was honored with the V. Parameshwara lecture oration in Jaipur a few months ago. And my main emphasis and main learnings, which I shared, was that we just don't want to look at diabetes, CAD. We want to look at everything and then make a decision. We must know the functional aspects of the cardiac system. We should know a bit more about the anatomy, if not by one test, then maybe 2 tests, if possible. Whether they're unstable, what's been their timeline, where do they fall in the natural history. And we should keep in mind that females in particular, poorly controlled hypertensives, a lot of diabetics, the most common cause of angina is not obstructive coronary artery disease, but it is microvascular angina. And you can simply treat that medically. You don't have to really bring them to the cath lab. And also have a plan in place for refractory symptoms should they come back to you having had all sorts of treatments and still not happy with their effort tolerance. These are just the usual pictures you would have seen over your last couple of years. We have these fantastic imaging techniques available now at different centers all around, and we are using them, maybe overusing them, underusing them, depending on where we live, where we work, so on and so forth. This particular slide is about CT scan and how CT scan has transformed investigative cardiology from a coronary artery and anatomy, and also structural perspective. Also, we could do CT-guided invasive angiography and make important decisions. I see that the CT scan shows you a lesion in the LAD here, which has been confirmed on this invasive angiogram, which was picked up on the non-invasive test here. And you can combine some stress protocols as well. You can do some advanced functional imaging combining with CT scans. But I think if you really have to think like a novice, a simple thallium scan done properly or a stress echocardiogram can give you as much information combined with some basic anatomy if you really had to assess somebody as to how far you really want to go with that. And that's a cardiac MRI. It's not universally available. We don't want to use it unless it's really necessary. And I don't want to dwell upon it too much in the context of diabetic coronary artery disease. This is not something we need in every single case. No, this just sometimes affirms our position in where we want to really take complex decisions in a more like MDT setting when we would refer to it. So I wouldn't, this is a completely separate topic for discussion. Acute coronary syndromes, well, this is a pretty much summary slide from 2015 that if you have ACS patients and if you randomly went on checking sugars, you might find that up to 2/3 would have, abnormal glycemia, and that is no surprise. ACS considerations over our practice or my practice over 2 continents, actually, that you could have, different symptoms. You might not have the classic chest pain. You may have a normal ECG. Of course, we know ECG can be normal in up to half patients. Your biomarkers may not be elevated. So don't just rely on everything. Just look at the patient properly. Focus on glycemic management. Try and intensify the statin. And where you think it's really relevant, go for an early invasive approach if it's available, if it's affordable for the patient, and make sure you use the pharmacology properly. And we have evidence to support that people who are high risk can be given up to 2 years extra beyond 12 months of a dual antiplatelet therapy where there are exceptional reasons. Otherwise, there's pretty much no role of carrying on beyond. And this has been further dissected in the recently concluded ESC meeting that in the future, we might be stopping things much sooner than 12 months, actually, maybe 3 months, 6 months, and just continuing with some monotherapy. And perhaps the clopidogrel might be better than aspirin, but the world, again, as I said, is changing as the science continues to evolve and give us more perspectives. Stop. There's nothing wrong with stopping if you're not sure what to do. And again, rehabilitation, preparing patients to go and have the right treatment, and then having the right rehab after what they have had. What to expect in the cath lab? If you bring somebody to the lab, this is just a list, but then colleagues with interest in cardiology would have seen everything and anything, to be honest. You can expect diffuse disease, you can expect access issues in vasculopathic profiles. You can have small vessel disease, branch disease. Often you want to stop and discuss, drug-eluting stents are the default. You always want to do ischemia-driven treatment rather than treatment based on angiographic appearances. And you want to minimize the contrast load and focus on hypoglycemic management. These are just some of the snapshots of what sort of things you can see in the cath lab, what sort of diffuseness of the nature of disease in diabetic patients, where you sometimes scratch your head and think, what do I do to try and get this person the best option? We often refer to MDT meetings, and this is a slide showing you occluded grafts in a patient with CABG quite a few years ago. No surprises. Now, I would like to spend just a few seconds on this ischemia trials, which the diabetes subset did not show any benefit with initial invasive treatment. It is important take-home message for the colleagues here who have not been familiar with these trials, because they have really changed the whole landscape of how we are offering revasc to elective patients with often triple vessel disease with moderate to severe ischemia on functional testing, or no symptoms, so on and so forth, and having an MDT approach. So on the left side, you've got what was 2019, that is now. You can see that there's hardly anything green except for left main disease and a left ventricular systolic dysfunction to be labeled as significantly impaired. Those are the only class 1 indications where you would, in stable ischemic heart disease, you would try and offer something more than medical management. Otherwise, you will try and medicate, and carry on optimizing risk factors until you feel it's no longer working. And this is where comes our heart team concept, where we try and, or you try and sit down with everyone who matters and make a concerted decision. I would like to end my talk with this, because this is what's kind of taken the world by storm, and we are not we are discharging every single patient from our hospital now as the default practice who has LV dysfunction on admission, or new LV dysfunction diagnosed or pre-existing on an SGLT2 inhibitor by default, and then leaving them to be followed up in the community if they qualify for the treatment. Now, GLP-1 antagonists, agonists, it's a completely separate area for discussion in a different forum. But I just thought I'll end up with slide because there's more evidence to come. We've got this very interesting combination studies coming out, and the general principles from 2020 are now taking a little backseat and trying to go more towards where we think we are now. And this is a paper from August, and exactly we had similar discussions in our ESC 2022 meeting just a few weeks ago that tailor the treatment. It's not just for everything else, plus an SGL2 or a GLP-1A, with or without combination. Well, time will tell. Perhaps very soon we'll know that. Thank you very much.